Now you can see it. Okay. Very good. Okay. Now you can see it? Okay. Okay, so we'll get started. We're talking a little bit about, a lot of people like to use the term C-spine clearance, and really clearing the C-spine is something that's done by the treating provider, sometimes the physician. Sometimes we won't even clear the C-spine until a day or two later, until a patient is woken up and cleared from his injuries. Sometimes with a head injury, for example, even if we've got a negative CAT scan and we don't see any evidence of a fracture, we'll sometimes leave a collar on until a patient is more awake and alert. So we're going to talk a little bit more about selective C-spine immobilization. People talk about clearing the C-spine in the field, and we try not to use that term. We try and use the term of selectively immobilizing the C-spine. If you have a question about that, we can talk about it at the end. So let's talk a little bit about neck injury. All right, so we're going to teach about a little bit about our objectives. First off, we're going to review some anatomy, and we'll talk about anatomy kind of down to the level that's important for you guys to understand. And then we're going to discuss some research and why we've come up with the rules we come up with. And then lastly, we'll review some recommendations for C-spine immobilization. I'm going to show you what I think is a good protocol, because those are the protocols that my colleagues and I have determined are appropriate for our region based on our level of training. And then your protocols may be slightly different in the future. But I'm going to review and go into some research so you understand why we came up with the way we did. And then we're going to talk a little bit about backboards and the current recommendations for backboards. Keep in mind that everyone is got a little bit different take on this, but this is research driven, which is primarily where I come from. So just in general, keep in mind that paramedics have a job because people always don't do the right thing. All right. So my goal here is to create thinkers out of you. Protocols aren't any good if you don't understand the reasoning behind it. What I call the monkey in the box, that's what we are in the emergency department. We just ask you to push the right button in order to bring the space capsule down. That's what ER physicians are sometimes. Just tell me what button to push and I'll do it. But what I want you to do is be thinkers. And the reason I want you to be thinkers is I want you to try and think what it is that we're doing and why you're doing the protocol that you do. So whether or not you are the Rodin thinker or the great thinker James Kirk, whatever it is that you're going to be thinking, we'll go over that just a bit. All right, so why do we have protocols to begin with? So the reason that we have protocols for the cervical spine is you have to think of the cervical spine as one long bone. And I'll go over that when we talk a little bit about the research about the bones. But the cervical spine gets the most important information or the most attention, but the spine itself begins with the cervical spine, thoracic vertebrae, lumbar vertebrae, and also the sacrum. It sounds like, Jason, maybe you need to mute yourself there. Okay, thank you. So there are 26 bones in the spine. Nerves and blood vessels run throughout, and we'll go over each section in a few minutes. Here is three views as of the spine. You can see that the very top first seven gain the most important because that's where the spinal cord causes the most intervention, all the way down to C7, which is where the diaphragm innervation is. Then you get into the thoracic vertebrae. There are 12 thoracic vertebrae, 5 lumbar vertebrae, and then the sacrum is consisting of 5 fused vertebrae, and then you get to the coccyx or tailbone. The cervical spine is the first 7 vertebrae, and these are probably the most important because this is probably the most fragile aspect, and it's where 50% of the flexion of the spine happens in the very first 2 vertebrae, C1 and C2. In a few minutes, I'll show you a little video, and that little video will help show you why one of the researches we talk about when we talk about the Canadian C-spine rules, why that's very important. But 50% of the flexion of and extension of the spine is in the very first 2 cervical vertebrae. It's the most flexible part of the spine, the cervical vertebrae, and the head acts as a weighted lever during normal motion. So when people get a whiplash, remember that the actual head itself is positioned. The very first vertebrae that you can actually feel is right here at C2. You can't feel C1 because it's in that area of the muscle that's behind. So if you take your hand right now and put it at the base of your neck and you feel the very first vertebrae, it's most likely you're feeling either vertebrae 2 or 3 in the back, because C1 is buried in the musculature. The thoracic spine is the next 12 vertebrae, and it's known collectively as the T-spine. It's much less flexible than the cervical spine. Vertebrae 1 through 10 are attached anteriorly to the ribs and the rib cage and sternum, giving the thoracic spine a whole lot more stability than the cervical spine. The narrowness of the spinal canal here allows for very little chance for movement of the vertebrae around the spinal cord, so it's pretty tightly packed in. The lumbosacral spine, we kind of consider those together. The last 5 vertebrae underneath the thoracic spine or the lumbar spine, and then the sacrum and the coccyx combined form the lumbosacral spine. There is an enlarged spinal canal here, and the spinal cord ends at about the level of T12 and L1. So if you have a spinal tap, for example, what we'll do is we'll put a needle in the area back here, usually between L2 and L3, and the spinal cord is actually ended by that time, and we're just not going to pierce it at all. The very end of the spinal cord comes down, and it's called the cauda equina. That's Latin for the tail of the horse. So at that point in time, the spinal cord, the spinal cord is pretty much just fibrous ends. So we're going to talk a little bit now about the spinal cord inside the vertebrae. The spinal cord consists of long nerves and fibers originating in the brain and going all the way down to L1 and L2, or T12 and L1. And the spinal tracts run through the cord, and they travel right to left. So you can see here where my pointer is what the spinal cord looks like. There's a dorsal root that's sensory, and these nerves are coming out of the spinal column. So you can tell when you get a fracture of the vertebrae, all these nerves and blood vessels are involved. So here is another representation of the spinal cord and the brain. Of course, your brain we talked about in stroke last month. And then as we talk about the spinal cord, you can see how it runs through the vertebrae, and down here at T12 and L1, the spinal cord kind of ends. And there's just, here is the cauda equina, also known as the tail of the horse, as it goes further down. You can see this is another high up here. This is where the spinal cord sits inside. These are called facets here and here, and this is where the next vertebrae above will rest. And you can see when we get a fracture, perhaps through here or here, how these nerves can be interrupted, or the spinal cord itself. Right now, there's no treatment for a spinal cord injury that's if there's a permanent transection of the spinal cord. So we're going to talk a little bit about the classic ways of treating spinal injuries. 20 years ago or 25 years ago, everybody got completely C-spine immobilized. So if you were in a car accident, there was no asking questions. There was no ability for the paramedic to actually look. Even if they did, with this poor guy who only smashed his finger, he got placed on a rigid backboard. He got placed into the foam here, and he was immobilized with the cervical collar, and there was no movement at all. Well, the reason we did that was somebody goofed up in the past. Somebody just laid somebody on a stretcher, and they probably had an incomplete spinal cord injury, or they were walking around at the time, and because they weren't immobilized, they moved their head, and the next thing you know, they were paralyzed. Well, in medicine, all we have to do is make a mistake once, and we forever change the way that we do things. But over time, we've looked at this and we said, you know, this isn't right. This isn't the right way to do things. Let's start thinking a little bit more about it. And we started bringing research into cervical spine immobilization. So the traditional approach was not all spine injuries are C-spine injuries, a tendency to ignore the rest of the spine, and I'll talk about that in a few minutes. A rigid cervical collar and long board for everybody. And those patients with a suspicious mechanism of injury, meaning a trauma, like you're in a motor vehicle accident, maybe you starred the windshield, you got fully immobilized, and a rigid collar and strapped to a backboard. But unfortunately, there's no evidence for doing it that way. And we try and think of ourselves as scientists. That's why you're doing all the prerequisites of science, and there's absolutely no evidence for that at all. In fact, it's like looking for a needle in a haystack to find that type of evidence. It makes good sense that if somebody is in a high-speed injury and we immobilize their neck, we won't cause any further injury. It makes good sense. And I'm sure somewhere in the past, a couple of people were not immobilized and they completed their C-spine injury, and that's the way that we got into treating the way that we do. But there's absolutely no evidence at all that that's the correct thing to do. So once again, here are the early paramedics. Humpty Dumpty's fallen off the wall, and the first thing we need to do is immobilize his C-spine, right? So we'll talk a little bit more about the science behind that. So this is what we typically would see. This is a British soldier who has been fully immobilized after trauma. And this is the typical approach. Fully immobilized, his neck will not move. He's on a rigid backboard, and there's no way that this guy's going to move at all. The problem is that this guy might vomit, and if he vomits, he's going to vomit straight up and down. It's going to go into his mouth. This pressure on the backboard, you try staying on that. I'm sure you've done this in training. When they immobilize you and they try and get you not to move, that's the most uncomfortable position to be in. These people need to pee, obviously. They need to get going. If they're old, the back of their head hurts, and it's just not very practical to do this to everybody. Of course, you know, there are times when there are actual injuries that need to be fully immobilized, like this, or like this, okay? There's no guessing that that's a mechanism of injury that might, in fact, lead to serious C-spine injury. But there are other things that happen. It takes a long time. We don't realize how long the patient's been on there. Compliance, nausea, aspiration, pain and unhappiness. I've never seen a patient who's happy to be immobilized. You can get pressure ulcers after as little as 15 to 20 minutes if people aren't moved. If there is a true C-spine injury and people have a fracture and they're paralyzed, this can happen even faster because they're not able to move at all. You're not able to ventilate well. You get an increase in your intracranial pressure, and we wind up with this physician workup bias. I have, early on in my career, tried frantically, before we started CAT scanning people, to get a good view of the C-spine, because you're supposed to see C7, T1, and if somebody is like that weightlifter we just saw, 300 pounds, there's no way that you can get a good view of the cervical spine. And there's a very famous picture, I think I've taken it out of here, of the C7 onto T1 subluxation, where you can see C7, you can't see T1, and then T1 is completely in front of the spinal cord. And because of that, we have this workup bias. So what the physician does is somebody comes in a C-collar, we wind up x-raying them, CAT scanning them, and increasing quite a bit of our workup. And it's kind of unfair to the patient to do that because nobody wants to miss a broken neck. At the same time, if we start using our thinking and immobilize people selectively, then we can do the right thing.
The apple accelerated at a rate of 9.9 meters per squared second.
All right, so why do I show this crazy little video? Because 1 Newton of force is what you need. 1 Newton of force is 1 kilogram per meter per second squared. It takes about 2,000 to 6,000 newtons of force to spine. So what happened is somebody went back and said, how much force does it take to break a cervical spine? So they did this great study back here in neurosurgery in 1983, and then they repeated it again in academic emergency medicine. And they wanted to see how much did it actually take to break a neck. So they took cadavers and they dropped weights on top of the cadavers' heads, and they measured the force it would take to actually break an intact C-spine. So a Newton is the amount of force required to accelerate the mass of 1 kilogram at the rate of 1 meter per second squared. So that's why I show that silly little video. However, the transfer movements of very low energy, even a hanging 4 kilogram head, that's about what your head weighs, about 8 pounds, off of a board is only 40 newtons. So even if there is a small possible fracture in the cervical spine, we know that it takes about 6,000 newtons of force to break a spine, and only about 40 newtons of force are used in moving a patient off of a backboard while you hold their head. And most of the time people will stop if they have a fracture, and I'll go over that in just a few minutes. So all of this work really goes to say that it takes a hell of a lot of force to break a neck, number one. And number two, that if a neck is broken, moving somebody from a backboard, rolling them in a typical fashion when someone else is supporting the C-spine, and moving them sideways to look at their back, or moving them from a board to a stretcher, it only takes about 40 newtons of force. So you're not going to really reach the amount of force that you need to cause serious injury. And most patients will stop if they have a fracture. Very often we have people who come in a day or two later who jumped in a pool or hit their head, and they actually have an unstable fracture, and the neck muscles go into spasm and they hold that neck immobile. So this is part of the research that was done on the cadavers. And this is the type of force that it took to break a C-spine. And you can look all the way over here into E. That's the type of force that it takes, about 6,000 newtons to actually break a cervical spine. Now, if this person is sitting, for example, traveling 60 miles an hour here in A, and they go from 60 to 0, and their airbag does not deploy, and they hit the windshield at 60 miles an hour, that's enough force to break it. But most of the time, if people are walking around and airbags deploy, etc., these injuries, they can happen, but they're not as frequent as we would like to think they are. So these are the ones that cause cervical spine fractures. Impact with a windshield if you don't have deployment of an airbag or you're not wearing your seatbelt. Diving injuries are very, very common. Very often, when you learn about drowning, we talk about drowning. These are the people who hit the bottom of the pool, perhaps suffer a spinal injury, and don't have the ability to swim out, and they drowned. So impact with a steering wheel and a reaction in a whiplash fashion can also do it if you're going from 0 to 60, for example. This is important because this was in the Annals of Emergency Medicine in 2005. And what is really important about this slide is this, that if you have injuries, the most common injuries to miss are C1, C2, C3. Those are the ones that are very, very difficult to palpate. You can't get up and feel C1, C2. Very often there's heavy musculature, so they're very often missed. X-rays are not as sensitive. And we do tend to miss a lot of the thoracic. I don't know why T12 sits here alone, or T7 sits here alone, but T11, 12, 1, 2, 3, 4, and 5 are very frequently missed. What we did find in one Archives of Internal Medicine and Surgery immobilization for trauma patients with gunshot wounds, this was actually published by a group of surgeons, and they found that when you had a high velocity gunshot wound in 1,000 patients, about 141 of those patients had some type of vertebral column or spinal injury, whether it was caused from the force of the blast or the fact that the patient fell violently afterwards. It was a pretty high percentage of patients there. Two patients, only 2 of those patients would have required immobilization in the field. One of the things that was very, very changing in the emergency medicine field was this study by Hoffman that was published in the New England Journal of Medicine in the year 2000. So we're almost 20 years into this Nexus study. Remember a couple of slides back, I talked about physician bias, that if somebody came in immobilized, we were very, very active in trying to do x-rays and make sure they didn't have a broken neck. Well, it was only back in 2000 that Hoffman actually started to do this Nexus criteria. And Nexus stands for the National Emergency X-ray Utilization Study. And he actually did some amazing work with nearly 35,000 patients. And he was the first person to come up with the concept of cervical spine clearance in the field, or what we call selective C-spine immobilization. So if they didn't have intoxication, distracting injury, neurologic deficit, or midline spinal tenderness, they didn't get a collar and they didn't get x-rays. They only missed 8 injuries out of 35,000. That's 99% sensitivity. And interval of confidence was up to almost 100%. Only 2 injuries out of 35,000 were deemed clinically significant that were missed. So that's a pretty darn good study. Pediatric spinal cord injuries are a little bit different. I just had one of these last month, and what they did with pediatric injuries is there's something called Swerka syndrome, spinal cord injury without radiographic abnormality. And kids have an inherent elasticity of their C-spine, which can allow severe spinal cord injury to occur in the absence of x-ray findings. But when they applied the Nexus criteria to pediatric, they found that the rule was almost 100% sensitive, and confidence intervals were also about 87 to 100%, depending on the study. So that was repeated just a year after Hoffman's study. Now, the Canadians have had managed medicine for years, and the Canadians, there are rules for everything, because the Canadians have decided that why do an x-ray, because an x-ray, number one, causes radiation, and number two, is expensive to do these x-rays. So the Canadians kind of took Nexus and then one-upped Nexus by adding one simple rotation to the right or left, which I'll go over in just a minute. But the Canadians published their study in 2001. What's different about the Canadians is just this little bit here. If you look at number 3, all of this here is pretty much, pretty much the same. They added a few other things where age were in there, a dangerous mechanism. And they added right here the ability of the patient to rotate the neck 45 degrees to the right and left. We've adopted this in our rules, in our protocols, and you simply decide if a patient has posterior midline tenderness, they're not intoxicated, they don't have a distracting injury, and then you ask the person to look to the right and look to the left, and if they'll do that, the chance of them having a significant spinal injury is pretty low. In a little video you'll see in just a minute, you'll see what I mean by that. So the Canadians, of course, studied about 9,000 people, and they claimed that they were about 100% sensitive. And there was an argument back and forth between the authors of the Nexus study and the Canadian study. It was kind of interesting to watch the banter back and forth. But most people agree that Nexus is pretty good, and then the Canadian rules, we follow the Nexus criteria, and then the Canadian rules, if you turn your head to the right and left, then you've got a pretty good understanding that there's no evidence of a C-spine injury. So when you put the two of them together, most people get about a 95 to 96% validation sensitivity. The Nexus authors responded that there were errors in the way that the Canadians classified distracting injuries. This is really just academic banter back and forth, but you can see that it went into 2000. It lasted for about 4 years and pretty much has quieted down. I'm going to go back one, and before I start this video, I want you to watch the cervical spine anatomy that we've talked about, number one. And number two, as the patient in this video moves his head to the right and to the left, you'll see that those facets, if they were broken, bones are painful. And if they were broken, the patient would not move their head. So go ahead and watch this video. There's the right and left right there. Okay, so we're going to talk a little bit about backboards. Whether or not a backboard is used, attention to spinal precautions and at-risk patients is paramount. So whether or not you use a backboard, you still have to selectively immobilize the C-spine based on what you see in front of you. Education of EMS and paramedics personnel should include the evaluation of the risk to spinal injury. And patients should be removed from backboards if they're placed on them as soon as practical in the emergency department. Very often, and I will do this, that you guys will drop off a patient, you'll take them from your stretcher and put them on my stretcher, and then you'll promptly leave the room, and I will promptly follow you out and say, hold it, you're not done yet. You've delivered me a patient, you've delivered your pizza, come and share in the pizza, and I'll ask you to help me get the patient off the backboard, because backboards are good for moving patients, but they're terrible for the patients to be on because they're uncomfortable. So in 2011, there was a great study about pre-hospital care and spinal cord injuries. And they actually looked at the literature and evidence-based guidelines. It was a pretty good study. And 4 key questions were created that were of interest. What's the optimal type and duration of pre-hospital immobilization in a spinal cord injury? During airway manipulation in the pre-hospital setting, what is the ideal method of spinal immobilization? What is the impact of pre-hospital transport time to definitive care on the outcome of patients with spinal cord injury? And what is the role of pre-hospital care providers in cervical spine clearance and immobilization? The answers were about 2% of all blunt trauma patients will have sustained some type of spinal cord injury. These rates are higher in the setting of severe closed head injury, like I showed you of the patient who stars the windshield. Patients with an acute spinal cord injury are at risk for neurologic deterioration due to secondary injury of the spinal cord, which we could see from all the anatomy we just reviewed. And a potential cause for secondary injury is inadvertent manipulation of the spinal cord in the setting of an unstable spinal column injury. That's what we try and avoid. This right here is why so many people get immobilized who probably don't need to be immobilized, and it's this potential cause of injury that leads us to do what we've always done. So what's the optimal duration of spinal cord immobilization? And there's no firm point cited in the literature after which immobilization should be discontinued. Several studies compared multiple backboards and multiple techniques for immobilization, and they all showed significant pressure increases within minutes in vital areas of tissue contact. So that's the back of your head, back of your shoulders, into your butt, and into your sacrum. During airway manipulation, really, the bottom line is airway control is done by using inline cervical stabilization. So you can do it without a C-collar as long as somebody is holding inline cervical traction, and that found did not worsen any neurologic status after airway management. So that's the reason that it's okay to immobilize somebody with inline cervical traction. What you do is somebody holds either from below or above. You know, you're supposed to be at the head of the bed when you're doing airway management. So somebody can actually hold inline cervical traction standing over the patient or from underneath the patient, and while you work. So they can do it either from on top or behind or from the side. And but that little bit of movement that you put into the C-spine to intubate somebody will not worsen C-spine injury. So airway management of acute spinal cord injury patients requiring intubation in the pre-hospital setting should include the use of manual inline cervical traction. Intubation of patients who have a spinal cord injury should not rely solely on cervical neck immobilization. That means somebody else should be helping them. And indirect methods of intubation, the glide scope, or some type of video-assisted intubation is probably the best, because in order to get a Miller or a Mac blade in there with direct laryngoscopy, you really have to crank that head back, whereas you don't have to do that with video-assisted methods. So what is the impact of pre-hospital transport time? Transportation was achieved both by ground and ambulance and fixed-wing aircraft, and 84% were transferred within 24 hours after injury. So you have somebody who has a spinal cord injury, and you have to get them to a place where a neurosurgeon can take care of them. Maybe you're transporting to a small level 3 or 4 facility without a neurosurgeon, and most of the time 24 hours is fine. There's no significant difference found in the probability of improvement between ground and air transportation. So if all you have is an isolated neck injury, you don't have to fly them out on a helicopter. Clinical evidence reveals that pre-hospital emergency medical technicians, this is really important, EMTs, can be trained to apply criteria to clear patients of cervical spine injuries in immobilized patients suspected of having a cervical spinal injury to a level similar to that of ER physicians. So this study by Armstrong in 2007 essentially said that if you follow the same nexus criteria or modified nexus criteria and treat patients in the field by the things that we had just talked about, that an EMT is just as good with training as an ER physician in detecting whether or not somebody might have a cervical spine injury. That's a pretty bold statement, but we found it to be pretty true. So that led to a position statement it took us years to get this going, but the National Association of EMS Physicians, of which I'm a member, and the American College of Surgeons, who own advanced trauma life support, those are the protocols that ER physicians and doctors have to follow when taking care of trauma patients. So these two organizations finally got together and they came up with a position statement. We had been asking them for years. And it essentially said the following: the use of long backboards has long been a staple in the treatment of transportation of trauma victims for several years in EMS, approaching the level of dogma. Dogma means essentially a belief or a faith that something happens and will happen. It's kind of like your faith in your religion is dogma. In recent years, selective spinal immobilization has allowed the paramedic to think on his or her feet and use a rational set of protocols to selectively immobilize the cervical spine. As with any dogma, people begin to question the reason behind hard and fast rules that are sound in theory, but not necessarily based on fact or research. So recently, the National Association of EMS Physicians and the American College of Surgeons got together and they came out with a new position statement. And this is it. Long backboards are commonly used to attempt to provide rigid spinal immobilization among EMS trauma patients. However, the benefit of long spinal backboards is largely unproven. So if you go back to my slide that showed there was no evidence and a needle in a haystack, somebody finally copped to it and said, we agree. The long backboard can induce pain, agitation, respiratory compromise. Furthermore, the backboard can decrease tissue perfusion at pressure points, leading to the development of pressure ulcers. And the utilization of backboards should be judicious so that potential benefits outweigh the risks. So, EMS and the use of the long backboard may include patients with blunt trauma and an altered level of consciousness, spinal pain or tenderness, neurologic complaints such as numbness or motor weakness, anatomic deformity of the spine, which means a step off if you're actually pressing on the spine, and a high mechanism of injury, like that 60 mile an hour to zero, and drug intoxication, inability to communicate, and distracting injury. So very much like the nexus criteria, the backboard should only be used in these situations. Furthermore, they went on to say that immobilization is not necessary if you have a normal level of consciousness, meaning a GCS of 15, no spinal tenderness or atomic abnormality, no neurologic findings or complaints, no distracting injury, and no intoxication. Patients with a penetrating injury to the head, neck, or torso and no evidence of spinal injury should not be immobilized on a backboard. Spinal precautions can be maintained by the application of a rigid cervical collar and securing the patient firmly to the stretcher, and may be most appropriate for patients who are ambulatory at the scene, who must be transported for a protracted period of time, like an interfacility transfer, and patients for whom a backboard is not otherwise indicated. So what they're actually saying in this is, yes, if you decide to put somebody in a C-collar, that's fine, but you don't necessarily have to put them on a hard backboard. So what we're doing in our area is we're putting the C-collar on if we have suspicion of a cervical injury, and getting them onto and transporting them with very low force movements, getting them onto a stretcher and keep them immobile as best we can. And if somebody's up and walking around at the scene, chances of them needing a backboard are kind of minimal. There's still some resistance with some of the medical directors who still insist that patients be placed on a backboard. Sometimes no matter how much evidence you show people, they're still going to do things the old way. So what does a practical, safe, scientific, selective C-spine protocol look like? And this is the one that we've come up with. Treat per universal patient care. All right, that goes without saying. Patients with penetrating trauma to the head, neck, or torso and no evidence of spinal injury should not be immobilized on a backboard. Appropriate patients to be immobilized on a backboard include those with blunt trauma and an altered level of consciousness, spinal pain or tenderness, neurologic complaints such as numbness or motor weakness, anatomic deformity of the spine, and high mechanism of injury, and any of the following: intoxication, inability to communicate, or distracting injury. This inability to communicate also goes for a language barrier. So sometimes if somebody speaks a language and you can't understand them, you're going to have to follow the rules and immobilize them. So perform a range of motion test if the patient does not meet mandatory immobilization. Complete secondary exam is something that you're going to do for neurologic status anyway, and treat pain as necessary. So if any doubt, you can always immobilize somebody. Range of motion should not be assessed if the patient has midline spinal tenderness. So remember the video I showed you? In that video, the patient turned their head to the right and left, and they looked up, they looked down. If they've got a fractured neck, it's going to hurt. And you're going to, even if you're not able to palpate 1, 2, or 3, that video showed you that if you miss the spinal injury, 1, 2, or 3, which we know are the most common to miss, and the patient won't move their head to the right or left, or if they have pain moving to the right or left, or up or down, then they require a collar. So consider immobilization in a patient with arthritis, cancer, dialysis, or underlying bone disease, because these people can fracture easier. Long spinal boards have risks and benefits and have not been shown to improve outcomes. We just talked about that. And spinal precautions can be maintained by the application of a rigid spinal collar, securing the patient firmly to the stretcher, and may be most appropriate for patients who are found ambulatory at the scene, who must be transported for extended time, and for whom a backboard is otherwise not indicated. So we just copied and pasted the recommendations into our protocols. Key considerations: mechanism of injury. They're going to be different for everybody, but ejection from a motorized vehicle, motorcycle, scooters, victims of shallow water diving, which I already showed you. These are concerning mechanism of injury. And then we said, what's a distracting injury? A distracting injury is something that includes a long bone injury, like a fractured femur, a large laceration or degloving injury, large burns, or any other injury producing functional impairment. So a distracting injury is not a cut, a small cut. A distracting injury is an injury that's so large and significant that a patient is thinking about that injury and not their cervical spine. Inability to communicate, we talked about that. Cannot clearly communicate. Examples are speech or hearing impaired, and those who speak only a foreign language, and small children. Sometimes kids will not talk or they can't talk, so we'll play the devil's advocate and immobilize those children. And intoxication, you know what drunk is, right? But difficulty with cognitive function, answering questions, slurred speech, unsteady gait, or difficulty ambulating.
Det viktigaste når du har løftet, så gå til sides etterpå. En gang du har løftet. Helt ut av bildet. Litt lenger av bildet. Kom igjen! Fy faen.
All right. So, questions.
If you guys have a question, you can unmute your mic and ask.
I have a question.
Sure.
Okay, I responded to a deceased person a couple weeks ago. EMS was disregarded. They said there were flies and everything on the doors of the trailer. So we arrive on scene. This guy's face is melting off. He's got a cord around his neck. Well, his feet, it was almost as if he was standing up. So I'm curious as to how he was able to deliver that force enough to the point where he was actually successful to hang himself. I'm wondering if it was because of a C-spine injury that he was able to actually break his neck and sever his vertebrae, or do you think he suffocated? Because it was almost like he was just standing up. I mean, he wasn't hanging.
Right, right. So the cord was around his neck and around his feet?
No, it was just around his neck, but he was on his feet.
Oh, I see. I see. To me, it sounds like it was most likely suffocation. You know, when I first talked about this, I've changed my lecture over the years. It's interesting that you asked that question, but I've changed my lecture over the years. And we talked about the force it takes to break a neck as about 2,000 to 4,000 pounds. And very early on, I had a slide that talked about what it took the force it took to drop and break a neck when we used to hang people. And there were drop tables based on a patient's weight. And, you know, because what they tried to do when they use gallows is actually snap the cervical spine right away so that patient died quickly rather than slowly strangulate. And unfortunately, sometimes they made a mistake. The table was published in kilograms, and at one time they actually had a person drop too far, and they actually separated their head from their body. So there is a science behind it. Believe it or not, most of the time we don't have that science anymore because we've gone away from hangings to other methods of execution. But most of the time in somebody like that, it's probably just strangulation, not really. It takes a fair amount of force to break the neck, and you actually have to drop a couple of feet to do that. So your patient most likely just suffocated, and eventually the electrical cord cut off his circulation to his brain, and he stopped breathing.
Okay.
I've got a
I did
question.
not. I didn't get to hear all that because I was very in and out with my connection. But thank you, Doc.
You're welcome.
I've got a question. One of the things that we come across pretty frequently in fire EMS is an extrication or a difficult extrication from a vehicle. Obviously a significant MOI if you're doing an extrication. You talk about the severe amount or the extreme amount of pain or pressure necessary to, damage a spinal cord with an intact vertebra. We try to keep the patient as immobile as possible via, your KED or your
Right.
long spine board, short spine board, and all that during the extrication. If you have a jagged or a broken vertebra, or obviously you don't know X-ray machines, you don't know it. How much force is generally required? What's your margin of error there without causing further neurological damage to your patient who may or may not have a spinal injury? I mean, do you have any input on that?
Well, yeah, it's kind of a loaded question. I mean, obviously, if you've got a prolonged extrication, you've got significant high energy to the vehicle. We tried to initially, we used to say if a vehicle was traveling over 45 miles an hour, that was considered high energy. And we had a lot of questions, people didn't know if it was traveling fast, etc. But if there is significant force that you're having to extract a patient and you've got maybe, let's say, a bent steering wheel, for example, that's pretty much a distracting injury. And in those particular cases, somebody should be immobilized, especially if you're trying to get them out of the car with a KED or something like that. It's okay to put a collar on a person and get them out of the vehicle and, protect them from that weight of their head flexing forward or back. We talked about, a head weighs about 8 or 9 pounds. So you try and minimize the immobilization. Plus, if you're getting to the point where you're trying to extract them from the vehicle and they've got other things going on, you're going to try and, I would in that situation, probably just put a collar on them and then get them out of the vehicle and then try and reassess them. What is important though, I don't have a problem with that, especially if somebody's got a head injury, for example, all bets are off. But if somebody's up and ambulatory at the scene and maybe they were in a fender bender, those people used to come in full spinal immobilization, and it was just a bear to try and evaluate them. And people got unnecessarily radiated with x-rays or CAT scans, etc. So I don't know if I answered your question, but a little bit of flexion and extension of the C-spine, most of the time these people will hold their cervical spine rigid, especially if there is a fracture. The body knows it. The body's smarter than we are. And it's a difficult situation, but if you've got a mechanism of injury that is so much that you've got that type of external force, the chances of them having a cervical spine injury are significantly increased. Did that answer your question?
Yes, it does, and it gives me a little insight. We have some old school paramedics that we work with on our department that if they're involved in, even if they're walkie-talkie on scene, and they want to go to the hospital, they're getting transported to the hospital, they're getting the full package. So
yeah, and that just doesn't make sense because it just makes my job easier.
Delay time and all that.
Yeah, and it's hard to teach an old dog new tricks, and I'm an old dog, but I will definitely change my protocols based on evidence, and we have one of our medical directors in this area who will not allow his paramedics to not put somebody on a backboard. And I just, I have academic discussions and he's going to do things the way that he wants to.
Thank you for your time, Doc.
You're welcome.
Doc, there's a question about the Babinski sign in a patient with spinal trauma.
I'm sorry, what is the question? I'm not
So
seeing.
it's from Elise. Can you describe what the Babinski sign indicates in a patient with spinal trauma?
Oh. The question is, can it explain a Babinski sign? Babinski sign is really not for spinal trauma. It's more for stroke. You know, where you're, Babinski sign is where you're rubbing the bottom of the heel and you're trying to see whether or not the patient dorsiflexes their foot. I really wouldn't use a Babinski sign in evaluation of the C-spine. It's really kind of a subtle sign, and it's not as, it's a textbook type of thing that it's not very practical. What is practical is asking the patient, can they propriocept is the word, which way their toe is going. So you know, if they're looking straight up and down, you ask them, am I pushing your toe down? Am I pushing your toe up? And then you grab their pinky toe and you say, which toe am I touching? And then is it going up or is it going down? Or does this left one feel exactly the same as the right one? So you want to get down to that basic level of can they feel normal, or are they complaining of numbness? You know, if they're complaining of numbness, all bets are off. There are people, for example, pediatric patients who get stingers. What we say, you know, I had a kid last week who had was in a wreck. His C-spine was negative, but he still had neurologic changes of his lower extremity. So I went and did an MRI. MRI was normal, but he still was complaining of these, what we call stingers, you know, some pain and tingling in their feet. And that will go away in time. That's like a stretched nerve that will recover. So back to your basic question about a Babinski, I would try and avoid a Babinski and trying to determine cervical spine injury. I'd be more specific as to left or right. Can they feel pinpricks? Can they feel things at the bottom of the feet? Remember, the older the patient is, or if they have diabetes, they may not have any feeling in their feet anyway. So that's kind of difficult. Ask them what it was like before. Sometimes they'll tell you the truth. And if you have any doubt, immobilize.
Alicia just sent a question, but she accidentally sent it to me. Oh, nope, she got it on there. Contralateral changes aren't necessarily indicative of spinal trauma, though, are they?
Oh, boy. Well, the question is contralateral changes. Well, that's a loaded question, and it's really kind of outside of this lecture today. There are, when I talk about, and I've taken some of those pictures out when I talk about spinal trauma because I think it tended to confuse people. There are three syndromes: a central cord syndrome, a Brown-Séquard syndrome, and lateralization syndrome, where people have part of their spinal column. If you go back to that picture, let me see if I can find it. Give me a second. Can you still see this picture here? When you get into the anterior, this is the anterior cervical spine. This is the posterior cervical spine. When you start getting into this horn here, this is the horn of the cervical column. When you start getting into the horn, there are all kinds of these spinal tracts cross over in different areas of the brain, and people can have contralateral symptoms. So very often that happens when somebody is stabbed in the neck, for example, and this area of the spinal cord is injured, and they might lose pain and proprioception on the opposite side. And that's kind of a higher level of knowledge than I think even the ER doc needs to know sometimes. But it makes us wonder what's going on. It has to do with all these tracks and where these tracks cross over. So contralateral signs are usually at this basic level. They happen down in here, and they're usually something, if you have somebody who has an injury to the right and they've got symptoms on the left, I would just, when in doubt, I would immobilize that patient and I'd let the neurosurgeon figure it out. And, you know, maybe the dumb ER doctor can figure it out, but I'd let somebody else figure that out.
Okay, folks, anything else, or are we ready to wrap this up for the night? Some great questions there.
Just keep in mind, as far as your own protocols go, your own protocols are designed by your medical director. You have to follow what your medical director says. In our area, we have something called a council, ECM's council, where medical directors get together and we all agree on a set of protocols. Sometimes there's some pretty vigorous debate, and like any good Congress, you know, we decide, and we'll go with the rule of the majority, and based on the evidence. And that's really what should be driving these things. So when we show this picture way back here of the, I think I showed the, here, this one, somebody mentioned old school paramedics. Well, old school paramedics need to learn every day, just as well as physicians, that there has to be evidence, and that evidence has to support what you're doing.
In Texas, we have a lot of old school paramedics. We also have a lot of old school docs who are the medical directors for EMS services. And Texas, as large as it is, each independent area medical director has its own protocols.
Right.
And what we do is we encourage you guys, because sometimes the only way you can educate the old school paramedics and the old school medical directors is to get involved in going to the what they call the Governor's EMS and Trauma Advisory Council meetings, which are typically held in Austin and also in association with the Texas EMS Conference. And there they have the Medical Directors Committee, they have the EMS Committee, where the movers and shakers get together to discuss issues such as this. And then sometimes the medical directors put out policy statements, position statements. But again, if that information is not making it back to your service medical director, you're not going to see much change in your system. You need to be involved on the state level in Texas, if you're a Texas resident, in trying to push through to make sure that your service stays up to the national standard of care.
Right.
Okay,
right.
It looks like we're done from what I can see here.
Thank you. Thank you very much.
Thank you all for coming.
You want to take over, Jane?
I've got it, sir. Thank you for your time.
All right. Thank you very much. I'm going to say good night, everybody. We'll see you next time.
All right, everybody. I've already gone in and given you credit in EMS testing. Make sure all your credits are there. If you're missing any, let me know and I'll research it. So you should be good to go. Good night, everybody, and we'll talk soon.
Thank you.